So, good morning, all of you. We will start with the second class of HIV/AIDS. Today, I'll start with epidemiology, which was the topic which we are covering on Monday. In epidemiology, we'll be looking into the global situation since the discovery of AIDS epidemic. Till when was it discovered? I told you it was in 1981, and so it's only 30-40 years since it has been there, and we have almost 80 million people who have been infected with HIV and almost 36 million deaths. This is a huge number. Now, prevalence in 2020 was around 37.9, which means 38 million people were living with HIV and with a global prevalence of 0.8% of the adults, only adults, 0.8%. Please don't talk. Now, South Africa has the largest HIV epidemic in the world, and World AIDS Day is on 1st of December every year. In India, the situation is a bit better. It's only 0.22% of the adults who are infected with HIV, and since 2001 the prevalence is decreasing. So in India it is bad for males, 0.22%, and for females it's 0.19%. We should not believe that this may be the true picture, because it may be that females are not getting tested. Okay, it should be almost an equal prevalence. Now, northeast states like Mizoram, Manipur, Nagaland, they have the highest prevalence. Please don't talk, you all also. The reservoir is not any animal or anybody, it's the infected people. Both symptomatic as well as asymptomatic people are the reservoir host. Once infected, they harbor the virus for life. The extremely high risk groups are female sex workers, men who have sex with men, hinjaras and transgenders, and IV drug users. All these are high risk group. Then there is a moderately high risk group also. It consists of healthcare workers. This is because they are exposed to people who are having HIV, and this can spread with needle pricks or splashes, etc. in the eye. During birth, it's also the blood or during surgery, the blood may be splashed on the face, and it can cause HIV. Hemophilics and other recipients of blood products, because they are having blood every now and then, they have blood transfusion. So it may be that sometimes in a window period the person may not be detected HIV positive, and he may donate blood which may be given to the hemophilics or other blood recipients, and then so they are also at a moderate risk of acquiring HIV. Then people living with sexually transmitted infections. There are many studies which indicate that the people who have STDs, they are more prone to acquiring HIV, mainly because there are lesions in the genitalia. Then opportunistic infections are very common, because as the name suggests, the disease is immunodeficiency disease. Hence, opportunistic infections are common. Fungal infections like oral thrush. Actually, in children who have oral thrush, newborns, in 6 months or 8 months, if they manifest with oral thrush, then HIV is the first differential diagnosis. Then frequent viral infections are seen, generally of herpes simplex. You all know herpes simplex manifests as lesions. It is a dormant infection. It manifests when the immune system is suppressed. And then CMV is also a viral infection which is manifested in immunocompromised people. Then common parasitic infections are Cryptosporidium parvum, which causes diarrhea, and Toxoplasma encephalitis. Now there are AIDS control organizations. Once this was an epidemic, then organizations were formed to control this illness, and the one which controls it globally is UNAIDS. It's a joint United Nations program for HIV/AIDS. Then in every country they have National AIDS Control Organization. In India, each state also has a AIDS Control Organization which is known as SACS. There is a national strategic plan for HIV/AIDS and STIs. Now the plan, it was a 4-year plan. Every time 4-year planning was done. Now the one which is running is from 2017 to 2024, which says that 95% of people who are living with HIV, they should know their status. 95% should out of those 95% should have get ART, and out of those who are getting ART, 95% should have viral suppression. This is the goal for 2030 of this strategic plan. Now the kinetics of the immune response as it happens when there is HIV infection. Initially I showed you graphs in which you could see that the viral load goes up as soon as there is infection. There is a transient period in which the virus is highest, and antigens of the virus, that is the P24 antigen, is also at the highest level, and then it decreases as the antibodies start appearing. The humoral response, which is helpful in this control of viruses in viremia, are IgM, IgA and IgG types. And generally they are against the structural proteins, regulatory proteins and accessory proteins also. So the window period of HIV is from 3 to 12 weeks. Now what is window period? Do you remember? Yes, can you tell me? Can you tell me what is window period?
During the window period, the virus shows no signs.
Window period is the period when you get infected, and till the time, no, not the symptoms, till the time antibodies are at a detectable level. Okay? If the person is getting infected, that is day 1, and antibodies will form, but they may not be at a detectable level. So that period, it may be 3 weeks, and this also depends on the type of test you are using. If we use 4th generation ELISA test, you may be able to detect the viral infection within 20 days, 14 to 20 days, but depending on the test, the sensitivity of the test which you are using, this window period can last from 3 to 12 weeks. I told you there are progressors, fast progressors, slow progressors, है ना? So it will depend on that also. If there are slow progressors, they may not show the presence of the virus for 6 months. The antibodies to the gag protein, that is P24, usually appear first, though antibodies to envelope proteins are also there. An infection progresses to AIDS. You understand? A person gets infected with HIV. At that time, he is not a AIDS patient. Can you explain why? Can someone explain that? A person is infected with HIV, but he is not a patient of AIDS. AIDS it's a syndrome in which immune deficiency will be manifested. It's the disease. When a person is infected with HIV, he is not a patient. You understand? He is not a patient. He just has a virus. But when the disease starts manifesting, say by 10 years or 8 years or 7 years, when he then has less CD4 count, then he is more prone to, then he has acquired a immune deficiency. At that time, the person is suffering with AIDS. Do you get this point? So, as infection progresses to AIDS, antibodies to P24 usually decline. When will a person go into acquired immunodeficiency? When his antibodies will be less. So, when the antibodies decline, then the person goes into this acquired immunodeficiency. However, antibodies to envelope proteins persist throughout the infection. Now, you must be wondering, when there are antibodies, then why should a person be suffering? The antibodies should be able to destroy the virus. But in HIV, I told you there is lots of mutation. Antibodies are formed against some part of the antigen of the virus, but it may mutate. The antibodies will then not work against that virus, the mutated virus. I gave you an example that at a single moment, if you take out blood from a same person from two different sites, there may be mutated viruses. Now, as for the laboratory diagnosis, 3 C's are very important. HIV diagnosis is not as diagnosing a patient of diabetes or leukemia or anything. This has a special way of being diagnosed. The 3 C's are important. You have to take the consent of the person in written. Whoever is getting HIV tested is supposed to write a consent that I agree to being tested for HIV. Then confidentiality. If one person comes for getting HIV tested, no one is supposed to know that this person is getting tested. I am not talking about the report. The report is actually very confidential. It has to be kept in lock and key. Even if the person is negative, positive and negative, both the reports are to be confidential, and the person is getting HIV tested, it cannot be made public. It is a confidential information, and counseling has to be done before testing and after testing, even if a person is negative. A person who is coming to get tested for HIV may be having a high risk behavior. I told you high risk groups. So those are behavior phenomena. So if a person is having a high risk behavior, he needs counseling. I'll tell you one incident where I felt that counseling was so important. There was a patient in TB hospital in Shastri Nagar. He came out to to be HIV positive. He was not counseled properly. He jumped from the window. He committed suicide. You understand? HIV is a stigma in the society. उसको ये लोगों को whoever gets HIV infection, they feel हमें family वाले नहीं support करेंगे, हमें like society में people will look down on us. So people get very emotional about it. I have seen people crying and getting, when they go through a high risk behavior, I have seen people coming every week to get tested. मैं दुबई गया था, वहाँ पे they had some extramarital relation and all that, and then they would have the this thing notion that they may get HIV positive, so they would come every week, cause nuisance. You know, so counseling is very, very important. Now, the tests of HIV are divided into specific tests for HIV and non-specific immunological methods. In specific tests, there are again three categories: screening test, then supplemental test, and then confirmatory test. Now, screening tests are those in which you detect the antibodies. Okay? You understand? You can detect either the virus or you can detect the antibodies. Both are present in the body. So, if you are detecting the antibodies, it is a screening test. Now, screening tests are of three types. Generally, it is known as ERS. E stands for ELISA, R for rapid, and S for simple test. Any of these three tests which have different principle. ELISA has a different principle. Rapid tests are those which will take less than 30 minutes. So they are called rapid test. S stands for simple test. The simple tests are those which will not require equipment. है ना, trained equipment, trained personnel वो नहीं ज़रूरत है, तो it becomes a simple test. जिसमें क्योंकि you can understand our country may not have electricity everywhere, so equipments may not run. So simple tests can be useful in places where there is no trained person or there is lack of equipment, especially in developing countries. These tests, the screening tests, they should be of high sensitivity and specificity. Do you understand the difference between sensitivity and specificity? Can you tell me? Yes, you with the yellow this thing, shirt. हाँ, आप या आप में कोई बता दो, दोनों येलो. हाँ, चलो बताओ. Can you tell me what is a sensitive test? कोई भी बता सकता है. Does anyone understand what is the sensitivity of a test? आप बताओगे? You know? जो आता है बोल दो. Doesn't matter. You learn to speak only.
The sensitivity of the test means the positive results, all the results which are positive would be seen, and in specificity the negative results would be
in sensitive test. Yes, is someone from there wanting to tell? Yes, are you wanting to tell? Can you make it clear?
Sensitivity is for identifying the patients and specificity is for identifying the people who are without the disease.
Sensitivity is for the test. Do you want to tell? Yes, bolo. नहीं. So sensitivity is, it is generally expressed in percentages. If there are 100 people positive, the test will detect 100. वो तो 100 detect करेगा ही करेगा. जो sensitive test होगा वो it can also detect 2 or 3, 4, 5% people who are not infected. It will not miss any positive. You get it? The sensitive test, उसकी जितनी भी sensitivity है, supposing the sensitivity of that test is 99.5%, which means it will detect all the positives it will not leave any positive, though it may have some false positives also. In specific test, they will detect the true positives. Get it? Out of this sensitive test, when we do the first test is very sensitive, it will detect some people who may not be positive, they may be falsely positive. So you test with a specific test which will rule out the false positives. It will detect the true positives. So these tests should have high sensitivity and specificity and should be confirmed. In HIV, there is a rule that you cannot report on one test. अगर फर्स्ट टेस्ट आपने जो करा वो पॉजिटिव आ गया तो यू कैन नॉट से दैट दिस पर्सन इज पॉजिटिव, उस आदमी को भी नहीं बताओगे. यू हैव टू कंफर्म इट विथ 3 टेस्ट. फर्स्ट टेस्ट शुड बी, मत बात करो उधर. First test should be a very sensitive test and the other 2 tests should be specific. So NACO has different strategies in India. Strategy 1, 2, 3, 4 strategies. Strategy 1 says is for surveillance. For surveillance, first is for transfusions, etc. If someone is having a tissue transplant, say blood transplant or kidney transplant, eye transplant, anything, so the donor is tested for HIV. The donor blood will be tested for HIV. In this, if one test comes positive, the first test comes positive, that tissue will be discarded. Blood will be discarded even if the first test comes positive and the patient is not, and this person, the donor, is not told that you are HIV positive. He is referred to a testing center. Got it? हम एक टेस्ट पे तो हम कह ही नहीं सकते कि वो पॉजिटिव है, पर उसका एक टेस्ट पॉजिटिव आ गया, so we cannot transfuse that tissue, but we can send this person to the testing center. This is the strategy for blood banks and other tissue transplant units. Then there is strategy 2, which is used for surveillance purpose. Every year there is a surveillance of high risk groups and low risk groups to know the prevalence of the disease in the society. Low risk groups are considered the pregnant women. They think that a pregnant woman is a happily married person who is at the least risk of acquiring HIV. So in that case, there is some number of cases, say 400 number of cases from each center, which will be taken and tested. So and there is a high risk group also. So all those people who are attending the STD clinics, they are high risk people. So some number 250 people from STD clinics. There are many centers, and all these will be tested, but they will be tested with 2 tests only. Blood tissue transplant, 1 test. This surveillance, 2 tests. अगर फर्स्ट टेस्ट नेगेटिव है तो नेगेटिव है, अगर फर्स्ट टेस्ट पॉजिटिव है तो यू डू द सेकेंड टेस्ट. इफ इट इज पॉजिटिव देन इट इज रिपोर्टेड पॉजिटिव, बट सर्विलियंस में पेशेंट को बताया नहीं जाता है. दे आर नॉट टोल्ड देयर HIV स्टेटस. ये एनोनिमस होता है. This test is anonymous. The person who are doing the test, they don't know किस person का ये blood है, because this is just for surveillance purpose to know the prevalence of the disease in the society. Then the third strategy is doing 3 tests. This is for diagnosis, in which you have to do 3 tests of different principles. They can be ELISA, rapid or simple test, and each has a different principle. So we should see the results of a single screening test should never be used as the final interpretation of HIV status, as false positive results or technical errors can occur. HIV अगर एक बार पॉजिटिव आया है तो वो जिंदगी भर पॉजिटिव आएगा, है ना. दिस पर्सन कैन नॉट गो इनटू अ नेगेटिव स्टेट till now, because till now we do not have medicines which will make the person HIV negative, except if he progresses to AIDS. जब वो बिल्कुल लास्ट स्टेजेस में होगा तो उसके एंटीबॉडीज नहीं बन पाएंगे, उसका इम्यून सिस्टम इज सो डेफिशिएंट दैट ही कैन नॉट मेक एंटीबॉडीज इवन अगेंस्ट HIV वायरस. तो दैट विल बी द टाइम व्हेन ही मे बिकम HIV नेगेटिव, बट उसके और एड्स के सिंड्रोम होगा. नाउ so this is ELISA test which is used in blood banks. It is sensitive, specific and cost effective. एक प्लेट में 96 टेस्ट लगते हैं तो 80 या 88 तो आप लगा ही सकते हो. रेस्ट कैन बी योर कंट्रोल्स. देन फोर्थ जनरेशन ELISA, इसमें ना जनरेशन्स भी हैं, फर्स्ट जनरेशन, सेकेंड जनरेशन, थर्ड. फोर्थ जनरेशन में एंटीजन भी डिटेक्ट होता है, एंटीबॉडी एंड एंटीजन बोथ आर डिटेक्टेड. So this is a very sensitive test. That is why I was saying कि this can be used in the window period to diagnose the person early. Now rapid and simple test. I told you about this. There are 4 principles of a rapid and simple test. It can be a dot blot assay, it can be immunochromatography, particle agglutination and dipstick or Coombs test. Then the third is supplemental test. These are highly specific test and they, अगर पॉजिटिव 2 पॉजिटिव आ रहे हैं, 1 नेगेटिव आ रहा है आपका बराबर, तो you can go for supplemental test. But these are very, Western blot सुने नाम? Western blot, that is one test which is a supplemental test. It is very expensive, labor intensive and experts are needed to do this test. Rapid or simple test में you can get it done with a simple technician teaching him how to pipette. Anyway, we don't need to go into detail. वेस्टर्न ब्लॉट में अलग अलग एंटीजन के अगेंस्ट में एंटीबॉडीज को टेस्ट कर लेते हैं. एंड WHO says कि if there are at least 2 envelope bands, so then it can be called a positive. CD criteria 3 bands कहता है. CDC, you know what is CDC? WHO तो पता है, CDC पता है? What is the full name for CDC? Center for Disease Control. Where is it? Who said Delhi? CDC कहाँ है? मतलब इट्स इम्पोर्टेंट, तुम लोग सब डॉक्टर बनने वाले हो. CD इज द अपना वो है लाइक मक्का मदीना टाइप चीज, है ना? मुरलीपुरा में हाउ नाइस. अगर होता मुरलीपुरा में तो कितना अच्छा होता. मुरलीपुरा वुड बिकम अ वर्ल्ड नोन थिंग, है ना? सीतापुरा नहीं बोला तुमने, थैंक गॉड. अब तुम लोग पता करके बताओ मेरे को कहाँ है CDC. US में है, कहाँ है? नहीं, इट इज आई मीन एटलांटा. चलो, first screening test should be highly sensitive, second and third should be highly specific. Different principles होने चाहिए. Supplemental test should only be done because they are costly, labor intensive. So supplemental test should be done only when it is in indeterminate report. Then अब बातें मत करो. Various tools available for monitoring the response to antiviral therapy is, अब antiviral therapy का एक रूल बन गया है कि the minute the person is diagnosed as HIV, 2018 या 19 में ऐसा वो आया था. पहले था कि जब when the CD4 level falls below 200, तब ART शुरू करते थे, फिर आया कि 350 पे शुरू करेंगे, फिर आया 500 पे शुरू करेंगे. अब ये है, अब द स्ट्रेटेजी इज टू गिव एंटीवायरल थेरेपी एज सून एज द पर्सन इज डायग्नोज्ड. एंड उसको फिर कैसे पता चले कि द पर्सन इज रिस्पॉन्डिंग टू एंटी रेट्रोवायरल थेरेपी? यू हैव टू डू द CD4 काउंट. आई टोल्ड यू CD4 काउंट उसके डिक्रीज होते हैं, है ना. डिड आई शो यू द कर्व इन विच द CD4 count will decrease as the disease progresses. So you can see, agar if the person is responding to the antiretroviral therapy, then CD4 count will either remain stable or will go up. So this can be used for monitoring the progress of the disease. HIV viral load, है ना. RT-PCR से आप वायरल लोड कर सकते हो. अगर वायरल लोड बढ़ रहा है तो दैट मीन्स द पर्सन इज नॉट रिस्पॉन्डिंग टू द रेट्रोवायरल थेरेपी. एंड देन there is a non-viral this thing also. Neopterin and beta-2 macroglobulin levels can also be used. See, there is a special note that viral antibody levels are inconsistent and variable during late stages due to immune collapse, hence not reliable for prognosis. As I told you, in the later part of the disease, antibodies may be negative. Then in pediatric population, diagnosis of HIV is a bit different because the child may have antibodies from the mother. The antibodies may be transmitted through placenta to the child during birth or in the later part of the pregnancy. So you cannot differentiate that the antibodies present in the baby are formed by the baby or by the transferred from the mother. So you cannot do the antibody test till 18 months of age, when the immune system of the child becomes working and it is able to form the antibodies. Then so it is different for children. Before all the maternal antibodies will disappear by 18 months. Therefore IgG assays, the antibody assays, can only be used after 18 months of birth. Though the tests which are recommended for children born to HIV positive mothers are dried blood spots. These are blood spots, blood collected on the blotting paper, which is then used for test. mat baat karo bhai, what is happening? Do you have something very important? Then you can go out. HIV, this dried blood spot is sent to places where they have the facility to diagnose the HIV DNA from the dried blood spot. It is eluted. The dried blood spot on the filter paper, it is eluted. The DNA from it is tested. HIV RNA may be tested. Then P24 antigen detection can also be done. In window period, as I told you, there is lack of antibodies. See, the definition comes here: time interval between exposure and appearance of detectable levels of antibodies. So you cannot detect the antibodies in this time. At this time, generally viral RNA can be detected, and RT-PCR may be the test of choice. Treatment is the goal of treatment. You cannot treat HIV. You cannot get a person rid of HIV. So the goal of treatment is prolongation of life, improvement of quality of life, because this person is going to develop AIDS, and AIDS he will all the time have opportunistic infections, diarrhea, so he will be having a very sad life. So it is improvement of quality of life. Then virological goals are that the viral load remains reduced and remains sustained at the reduced level. Then immunological goals are that it is a immunodeficiency. So immunological goal is that you maintain the immune system. Immune reconstitution is a good thing. Then transmission goals is that the person will not infect other persons. These are the goals of antiretroviral therapy. Now, indications to start ART antiretroviral therapy is as soon as the patient is diagnosed HIV, and there is one highly active antiretroviral therapy. This means that there is a combination of 3 drugs which are given simultaneously. All the 3 drugs are to be taken together. Can you tell me one reason why 3 drugs should be taken together? TB में भी देते हैं ना 3
Because the virus mutates.
so that the virus may not develop resistance by mutation to one drug. एक drug देंगे, the virus will get used to it, mutate and form a mutant progeny. So in this case, it is highly active antiretroviral therapy which suppresses HIV and progression. Then monotherapy with single dose is contraindicated. It is inefficient and there is chance of development of resistance. Opportunistic infections have to be treated before starting the ART. For people who are HIV positive and whose CD4 level is lower than 300, they should be treated, they should be given preventive medicines for the opportunistic infections like pneumocystis, pneumonia, cryptococcal meningitis and isoniazid, because TB is one of the most important opportunistic infection in HIV, so isoniazid is also given. There is one thing known as post-exposure prophylaxis in HIV. It is in short known as PEP. This is required to reduce the risk of transmission after occupational exposure. All of you are going to be doctors, you will be working with patients, and there is always a chance of having a needle stick, and during surgery you may have more exposure. So post-exposure prophylaxis is recommended for every person who has been occupationally exposed. Indication is if the person to which you are exposed is a known HIV positive person, or else if whenever a doctor gets exposed to some sort of blood or needle prick or any other injury, that the person who he is treating is to be got HIV tested. The patient is to be got HIV tested. If the person is HIV negative, then the doctor is a bit safe. And if the person is HIV positive, then the doctor has to take PEP. And if the person is unknown, कोई blood sample आया, unknown आपको exposure हो गया, तो then also the doctor needs to get a PEP. It should be started within 2 hours of exposure and continued for 28 days. And believe me, it's very toxic, so try and save yourself from such exposures. Then prevent neonatal HIV भी prevent करना होता है. All the pregnant women who are HIV reactive are initiated on lifelong ART. Their newborn is initiated on syrup nevirapine, and baby is also initiated on cotrimoxazole for OI. I told you children who develop oral thrush, they may be HIV positive, so they start cotrimoxazole and others. Now, vaccine. We were talking about vaccine. What are the hurdles? Which are, you know that till now, after 40 years of having HIV, there is no vaccine for HIV. So, there are a few hurdles because which For COVID, we got vaccine within 6 to 8 months. For HIV, it's been 40 years. So, high mutability of the virus. अब क्लास के एंड में तुम लोग जाना चाहते हो क्या बाहर? You will miss your attendance. मत बात करो. High mutability of the virus is the most important factor for HIV vaccine development. Long latency between exposure and appearance of symptoms. I told you it's almost 10 years in a normal person. Then lack of ideal small animal models for studying HIV infection. I told you the reservoir of HIV is only a human being. There is no animal who is susceptible to HIV. Then ethical issues, it is difficult to get human volunteers. अब किसी में आप वैक्सीन टेस्ट करोगे या बनाओगे तो उस पर्सन को पहले HIV से इन्फेक्ट करोगे, है ना? So there is this issue also, ethical issue. Then approaches are, there are almost 40 vaccines which are in trial, but none is done for now. In India also there is some modified vaccine which is being developed, but still it has not been in use. And none of the trials have been approved for human use till now. So the thing is, you understand why I am talking in detail about HIV, because this is something, if you acquire once, it is for life.